Welcome back to the 67th Annual LeRoy C. Abbott Society Scientific Program and the 54th Annual Verne T. Inman Lectureship. It's my pleasure today to introduce our distinguished 2023 Inman Professor, Dr. Tim Yoon. Dr. Yoon is a UCSF orthopedic surgery residency alum who has pursued a successful and noteworthy academic career in orthopedic surgery since leaving UCSF. He is professor of orthopedic surgery at Emory University Hospital in Atlanta, specializing in spine surgery. Dr. Yoon earned a degree in electrical engineering at MIT. He then went to medical school at Yale, where he graduated in 1994. He then earned a PhD in immunology at Yale the following year. Tim came to UCSF for internship and residency, completing the program in 1999. He did fellowship in spine surgery at Rush Presbyterian St. Luke's Medical Center in Chicago. After fellowship, Dr. Yoon joined the faculty at Emory University, where Tim has continued his orthopedic career over the past 2 decades, staying very active academically in the field of spine surgery. During this time, he served as chief of orthopedics at the Atlanta VA Medical Center from 2001 to 2010, and he is currently the chair of the Clinical Operations Committee for the Department of Orthopedic Surgery at Emory. Dr. Yoon's basic science research has focused on the cellular and molecular biology of intervertebral disc degeneration. He is also widely published in clinical orthopedics with an array of articles focused on spine surgery outcomes. Dr. Yoon has won multiple awards for his original scientific work and continues to publish recognized papers in spine surgery. He was recognized with the Harry Farfan Award from the North American Spine Society for his contributions to spine research. Dr. Yoon is also active in international orthopedics. He recently served as president of the International Society for the Study of the Lumbar Spine. In addition, he is chairman of the AO Spine International Research Group, the Degenerative Knowledge Forum. Dr. Yoon has enjoyed a rich and productive orthopedic career with many achievements as a surgeon, educator, and researcher. Tim, it's my pleasure to welcome you back today to UCSF as a 2023 Inman Visiting Professor. On behalf of the Abbott Society, thank you for joining us.
Robert, thank you for that kind introduction. I'm very honored to be back here. I remember my days as a resident, and I would never have dreamt that I would be back as an invited speaker in this kind of a capacity. I want to thank all the Abbott Society members also for inviting me and the warm welcome that I've gotten from each and every one of you. Before I start, I would love to get a little quick poll to see how many of you do any spinal surgery. Okay, so just a small handful. So this is going to be interesting, okay, because this is a spinal surgery talk. All right. So we'll try to make it interesting here for everybody. These are my disclosures. I do have consulting relationships and financial relationships with some spine companies and funding from a variety of sources. So, is the audio on? Can we?
She had a grade 2 spine, at 4-5.
This lady is a Brazilian lady who had a 1-level spinal fusion surgery the day before. And there she is walking around and talking and just behaving like a normal human being. And, she's going to be going home with no opioids at all. And I saw this in Brazil when I was visiting Luis Pimentel because he was developing this relatively new procedure at that time in the early 2000s called the lateral lumbar antibody fusion. And I saw how much benefit this kind of MIS surgery could be. And I was ready to go home and adopt this technology. I also saw that this could be applied for things that were very hard to do for me. For instance, this kind of a central disc herniation causing spinal cord compression and myelopathy. Traditionally, I would take down the rib and push the lungs out of the way and do all this kind of stuff to do an open procedure to get this. And I was able to instead use this minimally invasive kind of approach where you could just push the ribs aside, put these retractors in, get the anterior column exposure, and you can see, you put your retractor right up against the artery, the aorta there, that's why it's pulsating a bit, and you can see the disc and get the job done. So, and you can see the before and after, seeing that I was able to get rid of that disc herniation in a much less morbid way than I was trained as a UCSF resident, Another reason I got really interested in lateral lumbar interbody fusion is because of my personal failure, and I'll share that with you. So here's a patient who had a 2-level stenosis and instability pattern with the spondylolisthesis at L2, L3, and L3, L4. And I decided to do, what for me at that time was just a standard operation, which was to do a posterior spinal decompression and fusion with pedicle screws. And if you just focus on the left-handed x-rays for now, the screws look good, they're big enough, they're long enough, I didn't do anything fancy, all I did was decompress the patient and just put those screws in. I thought I was, doing good. Of course, nothing like follow-up, right, to ruin your self-confidence. So here it is, 6 weeks later, the patient comes back to see me in clinic. She's miserable. And what you can see is that the disc height has now collapsed, and the screws are loosened, and she's just not doing well. And you get a CT, and what do you see? The screws have completely haloed all over the place, right? So, the reason, is there a laser pointer to this thing? Yeah, so if you look right here, you can see the haloing, and right here, the vacuum disc phenomenon, where there was no anterior column support in this particular patient, right? So I said, well, I got this new technique now that I've kind of mastered. Let me try out this approach and to try to fix this problem and provide the anterior column support. There it is, there and there, there. And then to fill that void where the bone was just washed away, I filled it with cement. And this is an elderly lady. I did not want to have to, do a fancy extension above and below and all this kind of stuff and do another big posterior procedure. Instead, this was a very simple 2-level lateral procedure. And then I had the radiology team put the cement in, and she did great. It was pretty amazing. So this is the kind of experience that led me to really want to adopt working on putting in anterior column support, okay? And I think that if I had known this at that time, I might have been able to prevent this kind of complication, right? So why is interbody fusion good? Well, just look at the geometry, right? There's 90% of the articular surface is really in the anterior column, in the disc space, right? And 20% of the articular surface for the spinal joint is in the facet joint, right? So because you have bigger surface area, you can have better biology as well as the better biomechanics. And this will lead to better fusion rates. So what we found as a profession as spine surgeons is that interbody fusions placed through the lateral side has some significant advantages over at that time, the prevalent way of doing interbody, which was to do a T-lift, which is placed from posterior. You can put in bigger cages, you can get better foraminal height increase, and easier deformity correction, like what you can see here, which is far easier than using a pure posterior approach with less blood loss. And certainly, if I can go back here for a moment, even compared to the standard anterior lumbar interbody fusions, the incision sizes are small, it was much less morbid, you didn't need a vascular surgeon to help you if you needed that. And here's just a prime example of a patient who had an L3, L4 spondylolisthesis and stenosis. And you can see that the stenosis here is central and in the foramen. And you can take this kind of person and do just about a 1-hour procedure like this. And they're home on post-op day 1. And this was before the days when we were really doing minimally invasive, T-lifts and all these kind of stuff. So for me, this was life-changing kind of surgery. And the whole key here is that you can restore the geometry by restoring the height of the disc. You can see the before and the after versions of it. So another way you can do this was, so in a patient like this, iatrogenic injury, the pars defect and the empty facet syndrome causing mechanical pain in this particular patient. And here we go, just a simple lateral surgery with pedicle screws being placed. And at that time, I thought I was being really clever to do a single position, what we call a single position lateral, so we don't have to change positions in the patient at all, do this all in the lateral position. And when you do that, it's, minimal blood loss, quick, you don't have to be a fancy schmancy surgeon, you can get this done. So it's a testament to the technique rather than the surgeon. And then I found that it's also very useful for adjacent segment. So we had an adjacent segment case presented by the resident earlier today. I think that was Jen. Adjacent segment problem is an issue. Even with the best surgeries, you get adjacent segment problems, right? And so here's a classic example, right? So this is somebody who had a previous instrumented fusion, L4, L5, and S1. Now they've got L3-4 stenosis and instability pattern. What would you do? So let's ask the audience, what would you do for this? Dr. Metz? Let's say all those things are okay. There's no hidden gotchas here. Just a standard, you would do a lateral. Okay, so, before the age of lateral, I would do a posterior procedure here, and that meant that I would have to extend my fusion all the way down to the sacrum, and take out all this hardware, add on another level. I mean, it's a very morbid procedure, very morbid, right? So now instead, I did this approach, which is lateral to get the disc height increase, and then do a flip and do a laminectomy in the back, and then put these cheap little trauma screws, right? This is my version of trauma surgery. These are way cheaper than putting in the pedicle screws, which at that time were like $1,200 a piece. So, and the beauty of this is the patient basically recovers like they had a laminectomy procedure rather than a big, huge open posterior procedure. So, a lot of advantages. Here's another way you could do this, and I've experimented with kind of this low density, less hardware, more cost-effective way of trying to treat these patients with adjacent segment degeneration. Again, these are just some titanium cortical screws in the back here through the facet joints and a standalone lateral. And this worked great for about 20 cases. And then I had a subsidence issue, and I said, maybe I need to do better. So then another option is to add bigger screws here. So this is a patient, another case of L4 to L5 fusion, adjacent segment degeneration, again at L3, L4. And so I modified, just putting in facet screws with this cortical screw kind of construct. And the beauty of this is you don't have to go take out all the old hardware, and you can just put in these cortical screws, and they're pretty strong. And you got the anterior column, which is very strong. And it works beautifully, and you don't have to do the big open dissection, and the patients can go home a lot faster. All right. So I showed you a lot of the advantages of doing lateral surgery, right? But the statistics show that only about 20 to 40% of spine surgeons have actually adopted this technique on a regular basis, right? So probably in this room, the people that I know probably are doing this lateral approach, but if you go out into the community at large, it's not as much adoption as you think. And so, that was the hope. Let's go to the reality, right? I think the reality is that even though this procedure seems to be easy to do in a cadaver, it's really not. Because there are things that you actually have to care about in a living human being, right? Things like nerve roots, things like blood vessels, things like bowels, And I'll confess, I had a bowel injury myself, and I know that one of my colleagues out there has a retractor named after him because he had a bowel injury. There he is, right there. He's going to be the most famous spine surgeon in my group, Bobby Tay. All right, so, it's not as easy as you might think, and then there's also a big difference between getting an L4 nerve root injury as compared to getting an L5 nerve injury. And we talked about L5 drop foot issues, right, in the morning. Well, I think of L5 injury as being like a below-the-knee amputation, right, kind of thing. When you have a quad injury like this, or an L4 injury, it's more like an AKA. You lose the control of your knee. So it's much more important in your function and your ability to walk. And so if you ever get a case where you have an L4 palsy, that's a big bummer, right? That's a real big bummer, much more so than getting an L5 palsy. So I think, there's that issue. There's the genitofemoral nerve, lateral femoral cutaneous nerve, and then there's also a certain amount of psoas weakness that you get because this has to penetrate the psoas muscle or at least retract it in some way to get the procedure done. And then, of course, the rare stuff like bowel perforation, vascular injury, those kinds of things. And cage subsidence was also an issue in the beginning before we understood that you had to be a little bit cautious about how you prepare the end plate and don't overstuff that disc space, right? But I think we have to understand that every procedure has risk, right? And so these are some of the risks and complications you can get from the traditional surgery, the PLIFs, the MIST lifts, the A-lifts. Each procedure has its own complications. And I like to say to my patients, even Tylenol has complications, so you have to be careful about it. So that takes us to this graph here where, that typical, technology adoption where everyone is excited. There's a peak of inflated expectation followed by the trough of disillusionment. When you first get your first major complication down there, and hopefully the slope of enlightenment. And I hope this is where we need to be right now, try to understand the proper uses and technique for this kind of procedure. So I will now cover some of the things that you think about to be successful in doing this procedure and not stay in that valley of disillusionment. So one thing you need to do is understand the anatomy and really understand, the limits of what's easy to do, which is based on that lateral X-ray. So that's the iliac crest, and that's the ribs, and some crests are high, some are low. Sometimes the ribs are really in the way, sometimes they're not. And then which side to go at it. Typically, if you go at it from the concave side, you can reach more levels. And then think about the rotation, and you have to look at the images for every single patient. And you have to remember the anatomy for every patient is different. And looking at the rotation, trying to understand where are the blood vessels, where are the bowels going to be, is there a decent fat layer between the peritoneum and your spine, things like that. And the neuroanatomy, I recently taught a course where one of the neurosurgery residents wanted me to teach them the neuroanatomy. And that's, yes, you should understand that these things exist, of course, right? But the issue is that for a real-life human being, these are three-dimensional, and they move around. There's not like just one location, and there's a lot of variability. So you can't just say, if I do this, follow this algorithm, I'll always be okay. You have to always be thinking about this case. And here's a distribution pattern of the nerves, definitely more in the way of the disc space the further down you go. So that makes, the 3-4, 2-3 levels very much safer. But then as you start to go a little bit into 4-5 and below, it's definitely the danger zones. And so I think that if you're docking at L3-4, generally you're going to be pretty safe where you put your retractors. But when you're going to L4-5, you definitely have to be more careful and consider using kind of docking slightly anterior and then pulling back kind of technique to help yourself. And I think this is where the neuromonitoring is going to be super important. The triggered EMGs can be helpful to let you know what direction the nerves are going to be at. And then the real-time SSEPs now that we're using might be of benefit in the future. Okay. So this is the kind of view that you would get as you go through the psoas. And you can get a wonderful view of the disc space sometimes. And sometimes, you're just going to have to work a little harder. You have to understand that there's something called a safe zone, and that's going to be bounded by the yellow nerves in the back, and you can actually see them on the MRI. And I always make a point to go over this with my residents and fellows when we do this. And and then there are the two different positions that we can do this in, either the lateral position or we can do this in the prone position. Okay, so let's, so cage size, a brief moment about that. To prevent subsidence, you want it to seat well, right? Bigger is better up to a point. Too small is not good, just bad, more subsidence issues. And let it sit on the ring apophysis where the best bone is at. And what I typically do is I'm more aggressive about decorticating the middle of the end plates, where I'm not relying on the biomechanics there, and I can use that for my biology instead. Okay? So front to back, middle is usually a good place. You go too far anterior, you're going to have problems with cutting the anterior longitudinal ligament. If you go too posterior, you're going to hit the nerves back there, and also bleeds a lot. So stay out of that place. And then avoid doing this, something that I did early on in my career, which was to go too far down. And here's L5S1, trying to do a lateral through here. And at that time, I was like, yeah, I can do anything. Let me give this a try. And what you do is you can actually go kind of anterior and kind of come in oblique to get to the L5S1 level. But just because you can do this doesn't mean that you should, because this patient, the main reason why I did it was he was 88, and I wanted to do a really kind of slick MIS surgery on this patient. But he ended up with dysesthesias for about 6 months. Now, thankfully, it got better, but that's too much injury to potential to the lumbosacral plexus. Not a good idea. So don't do that one. We know that lateral surgery can be really good for coronal plane correction. Pretty easy to do that, but not so good for the sagittal plane. You can get the disc heights, but it doesn't mean that you can actually create lordosis, right? So it's not really impressive. And the reason about that is that, when you have a bad disc and you got some kyphosis, sure, you can fill that space and regain some of that. But what if you need more, right? So I'll show you yet another complication of mine that thankfully turned out okay. One of my partners asked me to use this newfangled lateral technique. This was in the kind of mid-2000s, before they had any hyperlordotic cages, all this specialized equipment to do fancy lateral surgery. I went in there and put in the lateral devices, went in the back and did a facetectomy, and next thing you know, the cage started falling out the front because there was too much lordosis, and I had to go rescue that with this harm-style cage. I'm going to tell you, that's not an easy thing to try to rescue. So that worked out, but definitely was painful. This is not my complication, but I just wanted to show you that this is a recent complication that I saw in one of our lateral spine meetings. An excellent surgeon is trying to get some sagittal plane correction here, doing lateral technique. He thought it went great. He's like, yeah, this is great. I got it. It looks good. And then what happened? Well, you can see the spondylolisthesis here, the gap between, and it was horrible. And so he ended up having to revise this with a staged A-lift, A-lift cage instead of a lateral, and then extending up, that sort of approach to fix this. So there are potential pitfalls if you don't go in thinking, hey, I'm going to do an actual ALL release and plan on it. And the reason why ALL release is important is when you cut that anterior longitudinal ligament, that really allows you to get the correction, okay? And if I go back one, I don't have an animation of it, but once you cut that, the main limitation is going to be the facet joints in the back here, right? So I wrote a paper with one of my residents about that. Basically, if you put in a cage that's hyperlordotic, 30 degrees, and cut the ALL, you can get about 10 to 12 degrees of correction. But if you cut the facet joint, then you're going to double the amount of correction you're going to get. So you can get like over 20 degrees of correction, maybe 25 degrees of correction at a single level if you cut both things. So I'm going to present a quick case here, and I think, where is Sig? He was telling me that this is not, okay, there he is. I promised you I'd present a case of this. So this is a patient who came to me with this kind of x-ray, and you can see that his SVA is pretty good. Right? He's able to stand up straight, he's not deformed, but he had this previous fusion surgery, you know, L3 to L5, but now he's got a small slip at L23 here, 5, 4, 3, 2, 3, with stenosis there, right? So his measurements were this: 3 degrees SVA, and he had 60 degrees of PI, and the lumbar lordosis was 23. So a severe PI-LL mismatch. Right, Sig? You agree? Yes, okay. So now, you know, he's got the stenosis at that level. I'm just showing you the stenosis here. He's solidly fused at the previous fusion level. So then the question is, what would you do? And I presented this case at various different meetings, and it is incredible the diversity of answers that I get from this, right? So many different answers. Sig, what would you do for this one?
Exactly what you did, Tim. It's gonna be brilliant.
You don't know what I did yet. What do you want to look at? You want to look at this one? Yujang, how about you? You've seen this case maybe. You wouldn't touch it, okay. Lionel, what would you do?
Yeah, you know, one of the important things with getting lordosis is putting it in the right part of the spine. So although you can do an ACR at 2-3, that sort of puts the lordosis in a non-anatomic area. So the options, I think, I would definitely do a hyperlordotic ALA at 5-1 and get part of the lordosis from that. And then consider doing a lateral at 3, 4, and 4, 5 and a PSO at L4.
Okay, so pretty big operation, maybe 2 days worth of surgery. Yeah. Bobby, what about you? What would you do?
Well, it depends on what his complaint is.
Neurogenic claudication.
If he's got stenosis, then what you have to do is you can press his spinal down.
Right.
Right? So
Right.
he's got sagittal pain, he's standing up straight. You have a whole bunch of things that says that he needs to use CSF specialists. Anterior, posterior, fusion bellows, and then But the fact is just that, you know, if he's a relatively young person, he's fairly well compensated. There's always an opportunity later on to do a big operation if he really needs it. But I think what you need to do is to treat the problem, which is clear his complication, and then stabilize the spine if you need to, and get whatever you can get now, and deal with something later on if that's a problem.
Right, so the spectrum of answers that I've gotten are the UCSF special with the M&M to follow. I mean, I did a lot of that. And I've also had folks who said, you know, what you should just do here is just a laminectomy, an outpatient procedure, right? 2 different approaches. So, you know, I'll just tell you what I did, and I'll just give you the outcome. And I know, Sig, you're going to tell us that it's not harmonious and all that stuff. I get that. But, you know, so this is what I did. I did a lateral, okay? And then I did a facetectomy and posterior screws. And you can see that it did fuse beautifully, right? And you can see what happens before the facetectomy, right? Just anterior only. After the facetectomy, you get significantly more lordosis correction, and you can get beautiful fusion right through that cage. I don't know why, but my ACR is always fused well. I don't understand it exactly, but here's the thing. Here's the thing, okay? look at that long x-ray, right? Before and after. You can see that he was standing actually better, at least on that particular day, before the lordosis correction that I did, right? Which I think is what Sig is saying, is that you gotta correct it in a different way. If you're hoping to correct the sagittal plane with one segment at L23, it's not gonna work. I agree, Sig, completely. But here's the thing, he was happy with the outcome. The x-rays may not be perfect, but he was very happy with the outcome, and the complication rate of this particular surgery is very small. And you could argue why bother even putting in that lordosis at that level, but I mean, it's better than making it more kyphotic, right? Okay, so that's what I did. So, you know, I think ACR has a lot of advantages, you know, but it's very technical, and you need to know how to do that. And since this audience is not mainly spine surgeons, I'll skip all the techniques part here. And then just go on to say that the ACR multi-level is possible. You know, what that means is that if you need more than just 20 to 25 degrees, then you can get more by adding to do more levels. So here's 35 degrees of correction that you can get by doing tandem ACRs, right? And standing x-rays to prove to Sig that it actually was able to correct the deformity in this particular instance, okay? And they look natural, and it looks reasonably harmonious. And then if you need, you can add other procedures to it, like posterior osteotomies and whatnot. Now, the main reason why I'm showing this particular x-ray is that for the spine surgeons out there, you might think you need to, you always have to take out these screws first before you do anything in the anterior column. But actually, when the screws are loose, you can go anterior column first, like that, and then you can go ahead posterior and avoid having to do the 3 stages, you know, the back, front, back. We can just go side, back, and get nice correction out of it, okay? Do some osteotomies in back, and it can work out just fine. Now, there are times when you have to do more than just this. You gotta do an ACR with something else, like, okay? And so these are situations when the patient's already fused, right? Now, this patient was fused into kyphosis, so you can't do an ACR through a previously fused level, right? Now, this patient is fused flat and has proximal junctional kyphosis. So what I did in this case was I did an anterior column procedure right here first, then did the posterior, and did a PSO, and this is what it looks like. So, you know, we got the PSO, looks pretty decent. You get that extra correction up here, and then you can get a very nice completed correction. And I agree, Sig, you know, when the lumbar spine is flat and fused into a flat position, I think you need to do some sort of a correction through that segment with a PSO like this. But the addition of the ACR can be helpful to gain that, you know, the complete correction. So some warnings, you know, vertebral compression can happen if you're just banging this device in to try to get that extra bit of lordosis. So you got to curb your enthusiasm some. And then there's a limit to how much correction you can get. So I think this is the only time I tried a 3-level ACR. The issue is at some point the pedicle screw heads start coming against each other, and you can't correct it any more than that. So, you know, so there's some limits. I'll present a case that I don't want you to take away as saying this is something that you want to do, but sometimes you're just forced into doing. So this is a case that was sent to me like this. Someone from West Georgia had done this surgery for this patient with osteoporotic fracture. So any of you guys, residents, see this kind of surgery, just be warned. You know, people with bad bone, it's hard to fixate them with just some screws, okay? And went out to this horrible deformity, horrible pain. Patient is just miserable. And I have another case like exactly like this, where I tackled and I went into total disaster, but I'll show you my success case instead of that one. Okay, so here is what that patient looked like. And so what I did, which I thought was kind of clever, was I told her that, and she had stenosis to boot, right? So this is no joke. What I did was I delayed her surgery. I just delayed, right? I said, you don't want to have surgery, you're going to get a complication, you don't want to have surgery, you don't want to have surgery. But at the same time, I was treating her with calcium and Fosamax, right? And I kept delaying her long enough. And then, she finally said, I've had enough. I need to have my surgery. So, we did the surgery. And this is what I did, right? Lateral corpectomy. And it's actually quite difficult to pull those fragments out, at this chronicity. And then cemented every single level that I could find. Of course, we ran out of cement in the middle of surgery. What an ordeal that was. But I want you guys to see one thing here. Look at the x-ray. So this is the immediate post-op x-ray. Here's the end plate. Here's cement. Here's the cage. Look what happened here, right? So despite me, sending her to get all that bone therapy and whatnot and delaying, you can see that the bone basically just melted away. There's no more bone between the cement and the cage on the follow-up, like 6-week follow-up x-ray. Completely subsided. And a similar thing happened down here. So if there was no cement there, it would have just collapsed all the way through, obviously. So that's just kind of the takeaway message here, that try not to do the surgery if you can, and if you're going to do it, I think you need to but use every tool that you have to try to avoid disaster. All right, so I want to show you some kind of a gee whiz thing for us surgeons, spine surgeons anyway, which is, what kind of things can you do with this now? Like some of the younger guys, this is a former fellow of mine who works down the street at another university here. Fantastic surgeon, and this is his case that I just wanted to show you. You can see the scoliosis and preserved lordosis, or at least flexible, multi-level lumbar stenosis. And he was able to do this in a single position surgery. Can you believe that? So this was all lateral surgery, where he put in these cages from the side, and he did an A-lift with the patient kind of in a lateral position, right? And did all this, and then put the screws in from the lateral position, and was able to, recreate that lumbar lordosis. And he told me he did it all skin to skin under 3 hours. So wow, there's some amazing things that can be done with this kind of technology. Yeah. So in conclusion, I'm going to say that there are significant advantages and some disadvantages to doing lateral surgery. And you just have to learn how to do it well, how to plan and what all the gotchas can be. But it's still a very useful tool that I would recommend that you be able to have in your tool belt. You don't have to do everything posterior, you don't have to do everything anterior or lateral, you just need to be able to choose what's best for your patients. Thank you. Zig, come on, hit me.
Tim, I just want to congratulate you, and you and I trained in parallel on opposite sides of the country, and then we switched sides, and the evolution of your techniques, and just some great cases. And I also want to thank you because thanks for sharing complications. It's always hard to do that, and I think you're around friends here who respect you. That's why you're an invited professor. So I've got nothing negative to say at all, and I'm glad you felt safe presenting those cases. I just want to, in terms of an evolution, which of these cases, as you're doing these direct laterals, or we're probably evolving more towards anti-psoas approaches here, but what's your threshold for when to do this in the main hospital versus in your outpatient surgery center or your ASC center? What's your threshold there?
That's a great question, and I'm only going to be able to give you a theoretical answer because I work at an inpatient hospital. And what I do for my patients is that I tell them they're going to stay one night for these kind of procedures. They usually stay 3 nights, And I mean, it really, I don't understand it exactly. But I think it has to do with their expectation. You know, a lot of people in Georgia, I have to kind of deprogram their brain into thinking that if just because you had spine surgery doesn't mean you're going to be in the hospital for weeks in bed, right? I think that for 1 levels, you could get them to do this. You could do this as an outpatient procedure. I really do. But anything more than that, I wouldn't want to do that. I'd like to have the luxury to be able to keep them in-house and work with therapy and make sure they're doing all the right precautions and things like that.
I have a question. When I trained at Emory, every Tuesday, Thursday, and Friday was a flip day. So we didn't do a lot of these ACRs, at least not in 2006 or 2007. So my question is, how or when did you actually adopt this into your practice and doing it as a routine? I certainly didn't get the sense that that was in the repertoire when I was there. And my second question is, are you using C-arm or navigation? How are you imaging this during this treatment?
Okay, so most of these cases that you see were all done with C-arm. The one that I used navigation was for the cortical screws. I find that I don't like to have the radiation while I'm doing that, so having a navigation there is just really nice. In terms of adopting new surgical technique, oh my God, as you know, spine surgery is still rapidly evolving. You know, if you think about it, what did I learn to do as a fellow? I learned how to do a few procedures, laminectomy, ACDF, and a posterior fusion, and you know, some of the easier scoliosis surgeries. So many of the procedures that I do now, I did not get specifically trained for, you know, doing as a trainee, right? So I've had to learn how to do that and adopt it slowly. And you know, sometimes you have the luxury of seeing one of your partners doing that procedure and scrubbing in and kind of seeing how they do it. Sometimes I've just tried something on a cadaver and kind of thought about it and tried it out carefully. This particular technique, I went to courses and then I tried doing them, and then I actually went all the way to Brazil to watch Pimente do it. You know, when you go to Brazil, they actually let you scrub in and do the procedure yourself, which obviously we can't do here in the United States. And so it's kind of a gradual adoption process. So for instance, I'll tell you about my latest technique change, which is to do these prone as opposed to lateral position. And so the first time I tried prone, it was a freaking disaster, you know, kind of thing. The nerve root was right in front of my face. I couldn't do my usual tricks that I always do on the lateral side to get things out of the way and do my procedure. So I actually just like repositioned the patient to a lateral and finished it from the lateral position, right? But now I'm doing it, but part of that was because you just need to understand there's a different way to do things with a slight tweak in position. So now I feel very comfortable doing a prone lateral, you know. So I think it takes several shots before you get comfortable in learning how to do it a different way.
Hi, my name is Mohammed Diab. I'm one of the pediatric orthopedic surgeons here. And spine surgery is part of my practice. And I found a lot of your talk relatable, like why patients stay 3 days when you tell them 1 day. It's also in San Francisco, not just Georgia. But I would love your comment, because I took note when you talked about using cortical screws. For my whole practice, I've been worried about cost. And one of the ways that I reduce costs is I just don't put an implant at every level if I'm going to fix a deformity. So that's the ultimate cost saving is zero. Just don't put an implant there. But I also for years put regular AO screws in the pedicle instead of a $1,000 screw.
Yeah.
Do you think that's okay?
You know, I thought about doing a biomechanics study on the facet
Yeah,
screw
as we have here,
Yeah,
thinking about that.
But I never really did that. I'll tell you that my experience with those titanium AO screws, that they work pretty well.
Yeah.
You know, the times that I've had failure was in the anterior column where the graft subsided through because the bone quality was so poor. That's why I had the failure. But I think nowadays we have the bigger footprint cages now. Instead of the 18 millimeters, the 22 is what I normally try to use. That bigger footprint makes a difference, and I see less subsidence issues. I agree with you. I try to do a lower density, so I'll put in, if it's a long level fusion, I'll try to put in 4 screws above, 4 screws below, and then just kind of alternate.
Yeah.
Reduce the number of screws, or use really cheap screws like those trauma screws instead of these super expensive pedicle screws.
Yeah, the other part of your talk that I related to was your comment that it may not look perfect on an x-ray, but the patient is satisfied. Ultimately, that is the goal. And maybe we don't have to make them perfect every time.
I agree with you. Absolutely. Thank you for that comment.
Thank you, Dr. Yoon. I think we'll move on to paper session 2. Thank you so much.
Thanks.